The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, here with another edition of The Genuine Article, and I'm sitting with Dr. Benjamin Sirica, who's one of the members of the TIMI study group and also a consultant cardiologist at Brigham and Women's Hospital. And we're talking about the Merlin trial and a recent paper that resulted from that trial. And Jack, can you refresh my memory about the Merlin trial?
Definitely. The Merlin trial was a trial of moderate to high-risk patients with non-ST elevation acute coronary syndrome. We ended up enrolling 6,560 patients, followed them for a year, and they were randomized either to the anti-anginal agent Ranolazine, which was started in hospital, or placebo. And the primary endpoint was cardiovascular death, myocardial infarction, or recurrent ischemia. And we've showed the results of the primary analysis from about a year and a half ago, but what we have just coming out in JACC is the analysis of the patients who had prior angina before they actually were admitted with their non-ST elevation ACS. And it takes up about half of the patient population had a history of prior angina.
Good. So in this report in JACC, you're really dealing with just those people who had prior angina and then were admitted with ACS. And what was your endpoint in this trial?
We used the same endpoint of the primary endpoint of cardiovascular death, myocardial infarction, and recurrent ischemia. But we also looked at other metrics of recurrent angina, either the use or need for further intensification of anti-anginal therapy. We looked at worsening cardiovascular angina classification. And we also had a stress test at 8 months in these patients. So we looked at time to ST depression, time to symptom onset of their angina during these, and so these were the additional analysis on top of the primary clinical outcomes.
Right. So these patients are matched prospectively. The difference being the intervention of Ranolazine. So what did you find?
So we found that very consistent with the overall results, Ranolazine did not reduce either death or myocardial infarction compared to placebo. But there was a statistically significant, almost 30% reduction in the risk of recurrent angina with treatment with Ranolazine in patients who had chronic angina before they were admitted for their ACS. And we saw that was consistent regardless of the type of ischemia. So whether it was worsening of Canadian cardiovascular class, there was an improvement with Ranolazine. Whether it was hospitalization with unstable angina or with EKG changes, there was a similar reduction with Ranolazine. There was also, as consistent with the prior studies of Ranolazine in patients with chronic angina, there was a improvement in their exercise test performance with longer duration until their symptom onsets, longer duration total of exercise, and longer duration until they had ST depression on the EKG in the stress lab if they were treated with Ranolazine.
That's pretty impressive improvement of anginal status.
Mm-hmm.
How have you converted that into recommendations for the treatment of angina?
Well, I think we're very cognizant, and we are giving further data to support what are the guidelines, that there really are two goals in the treatment of patients with chronic angina. One is to reduce the risk of cardiovascular death and new myocardial infarction. And Ranolazine doesn't seem to have a role in that area. But the other important goal is to improve symptoms. And still, a lot of patients with chronic angina have persistent symptoms, even if they're on 2 or 3 anti-anginal agents. And I think in this very broad population of patients with chronic angina, we show that Ranolazine is an effective anti-anginal agent, has a good safety profile, and offers everybody another option to treat patients with chronic angina, especially if they've had an ACS in the preceding year or so.
Yeah, have you gotten a bit more aggressive with your ACS patients? Are you giving them Ranolazine even if they haven't proven to have refractory angina?
No, I'm still using Ranolazine as an anti-anginal agent. I think this study has highlighted the fact that a lot of patients who come in with non-ST elevation ACS have a lot of chronic coronary disease, have persistent angina. Sometimes their life is limited by their angina, and they're not actually that good at telling me about it until I push them. And so to really become more aggressive on reducing their anginal symptoms with any of the anti-anginal agents. But I think this gives us more information and confidence that ranolazine can be an effective part of that medication regimen.
Well, that's good information to have, because I think you really have hit on an important point. That is that many of our coronary disease patients still do have angina, and we haven't found the perfect solution to that. And a new drug like ranolazine can help. Thanks very much for being with us, and thank you for watching.